Lancefield.
I'm Carla Pecoraro.
And I'm Mel Akerman, and we're your hosts of the Uterine Sound Podcast, bringing you up-to-date information on all things ONG. Today we'll cover Group B Strep.
All right, Anne, in a nutshell, what is Group B Strep? Talk to me like I'm one of your patients.
Group B strep is a very common bacteria that naturally lives in a woman's vagina. It's not an infection in the mother and it's not a sexually transmitted infection. But if a baby passes through the birth canal with GBS, then there's a chance that the baby can become unwell. So we give antibiotics during labour to protect the baby.
Okay, great. Seems simple enough. Now let's get into the nitty-gritty. What actually is GBS?
The full name of Group B Strep is, are you ready for it? The Lancefield Group B beta haemolytic streptococcus agalactiae. Now, say you're a microbiologist in the lab, how are you going to work out that this particular bacteria is Group B Strep? Well, first we look at it under the microscope. Streptococcus can be seen as gram-positive, which look blue, round bacteria that tend to form chains. Next, we grow the streptococcus in blood agar, which is typically sheep's blood. The beta haemolytic species produce toxins that cause complete lysis of the red blood cells, which causes wide areas clear of the red blood cells surrounding the bacteria. Now, this is in contrast to alpha haemolytic species, which oxidize iron and hemoglobin and cause a greenish color on the agar. So now we have beta haemolytic streptococcus. We need to work out what Lancefield group it is. The Lancefield grouping was initially discovered by Dr. Rebecca Lancefield and refers to the presence of antigens on the cell wall, which can range from A to W. And these are detected through latex agglutination tests. Obviously, Group B Streptococcus contains the B antigen. So the Lancefield Group B beta haemolytic Streptococcus agalactiae can then be subclassified into a further 10 serotypes with varying levels of virulence, again also discovered by Dr. Rebecca Lancefield.
What a woman. Not only was she an amazing microbiologist, but I hear that she also makes a mean eggnog.
That's right. So Dr. Lancefield is also famous at the Rockefeller University, where she did most of her research for making an amazing eggnog. She would actually make the eggnog in the lab before Thanksgiving. Then she'd let it mellow for weeks and then serve it at the Christmas party. Her recipe is actually published online and we'll include the link on our website. But hilariously, other microbiologists have tested the recipe and determined that somewhere between 2 and 3 weeks of mellowing, all the salmonella poisoning disappears.
Delicious.
Have you guys tried eggnog?
We're going to have to this Christmas. If we all call in sick on Christmas Day, our bosses know why. So in general, when we talk about Group B strep, we're referring to Streptococcus agalactiae. And it's called this because this particular bacteria is also really common in animals and is known to cause mastitis in the udders of dairy cows. The name agalactiae literally translates to no milk.
So GBS is Streptococci agalactiae, which is beta haemolytic and contains the Lancefield Group B antigen. And we know it causes mastitis in cows, but why do we really care about GBS in humans, and especially in pregnant humans?
So GBS is a common bacteria that lives in the lower reproductive and gastrointestinal tracts of up to 40% of women. While the bacteria doesn't typically cause problems in healthy women, during pregnancy it can sometimes cause serious illnesses for the mother and the newborn. GBS is the leading cause of bacterial neonatal infection and can cause a severe sepsis, pneumonia or meningitis in newborn babies. This can lead to death or long-term sequelae. GBS infection in the mother can also cause chorioamnionitis. Group B strep was first linked to neonatal sepsis in the 1970s, and it was associated with a 55% mortality rate. The current mortality rate, The current mortality rate of early onset GBS disease is 1 to 3% in term infants and 20 to 30% in preterm infants. And this is thanks to Intrapartum Antibiotic Prophylaxis.
Great. So GBS is the Lancefield Group B beta haemolytic Streptococcus agalactiae. And I remember it because it's B, but the strep starts with an A. Aside from causing mastitis in cows, it also commonly colonizes up to 40% of women, and most commonly in the gastrointestinal tract or also the lower reproductive tract. It can lead to severe infection in the neonate or chorioamnionitis in the mother. So I've heard that neonatal GBS is divided into two clinical syndromes, early onset GBS and late onset GBS. What's the difference between these two?
Early onset GBS manifests from 0 to 7 days in the newborn, most commonly within 24 hours of birth. It typically presents as sepsis, pneumonia, and less frequently meningitis. It's acquired from vertical transmission through exposure of the baby to GBS from the vagina of a colonised woman. Now, most babies that acquire GBS through the birth canal only become colonised, not necessarily infected. So roughly 50% of newborns born to a GBS colonised mother become GBS colonised, and without preventative measures, 1 to 2% of these newborns will develop early onset disease. With our current prophylactic measures, the incidence of early onset GBS is 0.4 per 1,000 births. That's in Australia. Late onset disease affects infants from 7 days to 3 months of age. This typically presents as a bacteremia or meningitis, but often with really non-specific signs like fever, vomiting, and irritability, so it's often diagnosed really late. It can be acquired from the mother, from the environment, and result in hearing loss and mental impairment. Sadly, the incidence of late onset GBS has not changed with our intrapartum antibiotic prophylaxis.
Okay, so neonatal GBS can either be early onset, which is occurring within 7 days and presenting as sepsis, pneumonia, or meningitis, or late onset from 7 days to 3 months, presenting as bacteremia or meningitis. An intrapartum antibiotic prophylaxis has reduced the rates of early onset GBS to 0.4 per 1,000, but hasn't affected the incidence of late onset GBS.
That's right. So we know that not every baby that is colonised with GBS will develop infection, but how can we tell which babies will?
Well, we can't really predict exactly which babies will become infected, but there are some risk factors that increase the risk of a baby developing early onset Group B Strep. These include preterm labour under 37 weeks, prolonged rupture of the membranes over 18 hours, maternal temperature greater than 38 degrees Celsius in labour, positive Group B Strep swab in pregnancy, Group B Strep bacteriuria in pregnancy, or a previous baby affected by early onset or late onset Group B Strep. Those are ones to remember for your exam.
Yeah. So maternal colonisation is a big risk factor for early onset GBS. How do we test for GBS colonisation in pregnancy?
So GBS can be detected in 2 ways. It can be grown on a urine culture, or you can detect it on a low vaginal swab. So to collect the low vaginal swab, you would take a routine wound swab of the lower vagina and anorectal or perineal region. Remember, the bacteria typically lives in the gastrointestinal tract, so collecting an anorectal swab in addition to a low vaginal swab increases the detection of Group B Strep by about 25%. Ideally, you want to collect these swabs before you do a digital examination or before you use any lubrication. And importantly, you don't need to use a speculum, and the swabs can actually be self-collected by the woman. Now, collection is really important, and typically the swab should be done at the lower vagina and then inserted 1 centimetre into the anorectum. Don't go backwards. You don't want to insert it into the rectum and then into the vagina because, well, first of all, it's unhygienic, and secondly, you increase the risk of a woman getting thrush. Now, there is some evidence that a perianal swab is just as effective as an anorectal swab, but this is a little bit controversial in the literature. In Queensland, our current approach is to just do a low vaginal and a perianal swab. Now, the transport of these swabs is very important, so they need to get transported in a non-nutrient transport medium like Amy's or Stewart. And if the lab isn't going to process the sample immediately, then the sample needs to be refrigerated, as the recovery of bacteria declines over 1 to 4 days and can decline even faster at higher temperatures, which can result in false negative results. It's really important that you indicate on the referral form that the swab is specifically being taken for Group B Strep, and this is so that the lab can do the appropriate tests. Because maternal colonisation is being screened for, not active infection, the culture needs to be performed on selective enriched media in order to improve the sensitivity. False negative rates of up to 50% can occur without the use of this enriched culture media. Now, this media sometimes contains gentamicin, which actually represses the growth of other unwanted colonies of bacteria, which can actually obscure the findings of Group B Strep. Now, if the patient is allergic to penicillin, then this should also be indicated on the pathology form and antibiotic sensitivity is requested. And this is because the alternative drugs to the penicillins include clindamycin or lincomycin, and up to 20% of Group B Strep strains are resistant to clindamycin.
Yeah, to be honest, I don't think I've ever put a patient's allergies on one of these forms, but that's something I've learned from preparing this podcast.
Absolutely. Can I write low vaginal swab, or should I specifically say GBS in pregnant woman?
You should always write low vaginal swab. So typically what we write is LVS GBS, or if you're doing it in digital health, you write genital swab, and then in your comments write low vaginal swab GBS, and then a little note beside it if they're allergic to penicillin. Yeah,
that's such a good chestnut. Anyway, and what do we do with these swabs? Oh, when should we do these swabs? Sorry.
So the current recommendation in Australia is to collect swabs at 35 to 37 weeks of gestation. GBS carriage fluctuates over time, meaning a woman may be colonised with GBS early in the pregnancy, but then not colonised again at the time of delivery. The rectovaginal culture 5 weeks before delivery has a sensitivity of 91% and a specificity of 89% for intrapartum maternal vaginal colonisation. Given that 7% of births occur after 41 weeks, collecting the swab at 36 to 38 weeks extends a predictive window screening of up to 41 weeks. And that's the current recommendation in America. Cultural results are less predictive of carrier status if more than 5 weeks have elapsed between sample collection and delivery. For this reason, screening for GBS at term is predicted by screening at 36 to 37 plus 6 weeks gestation, or 3 to 5 weeks before anticipated delivery, particularly in high-risk women who need to be delivered preterm for other reasons. This is different for GBS bacteria. If a woman has GBS bacteria at any time in her pregnancy, she's considered a carrier.
And that's because it's an indication of really high colonisation. Is that right?
Yeah.
Great. So can we just swab all pregnant women for GBS and just treat those that test positive?
Good question, Carla. So here you're talking about universal screening, which is certainly one approach to Group B Strep, the other being risk-based treatment. This is a bit of a tricky subject, and there is currently no international consensus on whether to use risk-based or culture-based screening approaches. Currently, America and Canada recommend universal screening. The UK, Netherlands, New Zealand and Ireland recommend risk-based protocols. And RANZCOG, ACID, Queensland Health, New South Wales and Victoria recommend either approach.
So then what's the difference between universal screening and the risk-based approach?
Universal screening involves screening all pregnant women for GBS at 36 to 37 plus 6 weeks gestation and treating those who test positive for GBS with intrapartum antibiotic prophylaxis. Women who've had a previously affected baby by early onset GBS disease or those who have GBS bacteria do not require screening and will automatically receive intrapartum antibiotic prophylaxis. Women whose GBS status is unknown at the time of delivery are treated with intrapartum antibiotic prophylaxis using a risk factor-based approach. The risk factor-based approach involves no routine screening for GBS. Instead, at the time of labour, women are screened for risk factors and treated with antibiotics if they have any of these risk factors. The same ones that Mel mentioned before. So preterm labour, less than 37 weeks, prolonged rupture of membranes greater than 18 hours, maternal temperature greater than or equal to 38 degrees in labour, positive GBS swab in the pregnancy, GBS bacteria in the pregnancy, or a previous baby affected by early onset GBS disease. Neither strategy is perfect, and there's certainly arguments for and against each strategy.
And what are those arguments? Surely one strategy is better than the other.
Well, universal screening appears to be the best strategy supported by the literature. A 2002 large population study supported universal culture-based screening, prompting ACOG to recommend a universal culture-based screening strategy. More recently, a 2020 meta-analysis of studies comparing universal screening, risk-based protocol, and no policy found that universal screening was associated with a 57% reduction of early-onset Group B Strep disease compared with risk-based protocols, and a 69% reduction compared with no policy. Risk-based protocols were not significantly more effective than no policy. And importantly, universal screening did not lead to significantly higher rates of antibiotic use compared with risk-based protocols. And the current rate for each is about 30%, which is actually quite high. Now, the limitations of universal screening include over-treatment of Group B Strep negative women, keeping in mind that 17 to 25% of women who test Group B Strep positive at screening will actually be Group B Strep negative at labour. And then also the under-treatment of Group B Strep positive women. So if a woman tests negative at a 36-week screen, there's a 7% chance that she'll be positive during labour. Now, the RCOG in New Zealand do not recommend universal culture-based screening due to conclusions about cost effectiveness in the UK and New Zealand setting. In Queensland, the Queensland Clinical Guidelines recommend a risk-based approach as well, based on early onset Group B Strep rates in Queensland, the likely cost effectiveness of both strategy, and the quality of evidence in support of both approaches. It's important to note that New Zealand, who has a purely risk factor based approach, actually has one of the lowest rates of Group B Strep at 0.2 per thousand. Limitations of the risk factor approach include the fact that 25 to 30% of early onset Group B Strep disease cases are actually born to women without risk factors. Risk factors are also present in women who are not colonised with Group B Strep, so the risk factor based approach may unnecessarily expose many women to intrapartum antibiotic prophylaxis. And importantly, we routinely see clinicians and midwives collecting a low vaginal swab for Group B Strep and a high vaginal swab every time a speculum is done. If this is performed and the woman is Group B Strep negative and goes into labour within the next 5 weeks, according to New Zealand, she does not actually require intrapartum antibiotic prophylaxis for prolonged rupture of membranes. In Queensland, the neonatal management pathway also uses the risk factor-based approach, and these women should be given intrapartum prophylaxis, otherwise the baby will be subject to a full blood count at birth.
Yeah, wow. It is tricky when you see the for and against for both. Like, there are definitely pros and cons. I guess in that case, then, how do we prevent early onset GBS?
After scientists realised that GBS was the main cause of neonatal sepsis and that most GBS is transmitted from the mother, clinical trials were started to see if the administration of antibiotics to women in labour would reduce the incidence of early onset GBS disease. GBS isolates in the lab were susceptible to ampicillin and penicillin and were demonstrated in rhesus monkeys to treat and prevent early onset GBS disease in baby monkeys. So these were the antibiotics of choice.
Yeah, wow, what an incredible development. The poor little baby monkeys, though. Which antibiotic regime should we use?
The ideal antibiotic for GBS intrapartum antibiotic prophylaxis is IV benzylpenicillin, 3 grams once, followed by 1.8 grams every 4 hours IV until delivery. Although initial trials demonstrated that both penicillin and ampicillin are effective, it's better to use the narrower spectrum antibiotic of benpen, and therefore it's a better choice, so we can hopefully prevent our antibiotic resistance. It's interesting to note that so far there's been no cases of penicillin resistance among GBS isolates.
Also, like, whenever I'm on birth suite, I get everyone rushing to get antibiotics in at least 2 hours prior to birth. Like, why is that? Is it evidence-based?
Yeah, so it's more effective if you get your antibiotic prophylaxis administered at least 4 hours before delivery. So even though that's our goal, we recognise that administration 2 hours prior to birth is adequate prophylaxis when considering neonatal management. One study showed that fetal serum levels of penicillin are high within 30 minutes of maternal IV infusion. The maternal GBS colony counts begin to fall shortly after initiation of antibiotics. So after 1 hour, the colonisation rates drop to 46%. Within 1 to 2 hours, rates drop to 29%, and within 2 to 4 hours, they drop to 2.9%, which is pretty significant.
Yeah, wow.
So when administered more than 4 hours before delivery, the colonisation rates drop to 1.2%. If the birth is anticipated in less than 2 hours, administer intrapartum antibiotic prophylaxis as the benefits still occur. Importantly, we continue the dosing every 4 hours as recolonisation is thought to occur after cessation of therapy.
It's interesting, though, if the colonisation rates are reducing to 1.2% when antibiotics are given more than 4 hours before delivery, then why do we need to keep on dosing? How long does it actually take for recolonisation to occur? Maybe that could be an area of research in the future. Stat dose of penicillin versus continuous dosing.
Ooh. Do you make eggnog as well? What about if my patient has a penicillin allergy? Which antibiotic should we use then?
Well, first of all, it's important to determine whether the woman is actually allergic to penicillin. 80 to 90% of people who report a history of penicillin allergy are not truly allergic because the sensitization is lost over time, or the original reaction was actually not related to penicillin in the first place. So it's really important to get a description of what the woman actually experienced when she had penicillin in order to determine if she has a low or high risk of an anaphylactic reaction. If the patient has a low risk of penicillin allergy, for example, they had an itch without a rash without an itch, gastrointestinal symptoms, or an isolated headache, then it would be safe to give cefazolin. And these patients only have a 4% risk of having any kind of reaction with the first generation cephalosporin, such as cefazolin 2 grams IV every 8 hours. Now, a history of an itchy rash, urticaria or hives, immediate flushing, hypotension, angioedema, respiratory distress, or anaphylaxis after administration of a penicillin or cephalosporin are considered high risk of anaphylaxis. These are considered immediate type 1 IgE-mediated reactions that develop quickly and occur in the first hours after administration. These reactions occur in 0.7 to 4% of all treatment courses, with a risk of anaphylaxis of 4 in 10,000 to 4 in 100,000 in the general population. Now, if the patient has a high-risk allergy, then the usual treatment is with clindamycin or, depending on your drug availability, lincomycin. Now, remember, up to 40% of Group B strep isolates are actually resistant to clindamycin, which is why it's so important that we have sensitivity testing on our Group B strep cultures, and we only get that by telling the lab that our patient is allergic to penicillin. If the Group B strep is resistant to clindamycin, then our last resort is vancomycin, which is a pretty intense drug. Now, we can also consider allergy testing. This is safe in pregnancy, and it also has benefits in the long term if the patient requires penicillin in the future. Not to mention, it means we can use more narrow-spectrum antibiotics in order to reduce rates of antibiotic resistance.
And then, so why can't we just give antibiotics before labour?
Unfortunately, antibiotics for those found to be GBS carriers before the onset of labour has been shown to be ineffective.
Wow.
Those women have a 67% recurrence rate of GBS colonisation later in pregnancy, so we don't typically treat GBS detected on a low vaginal swab. Remember, this detects colonisation, not infection. This is different to GBS on urine, however. We know that women who test positive with the GBS UTI are much more likely to have high rates of GBS colonisation with more virulent strains. GBS UTI can also increase the risk of pyelonephritis and preterm labour. So we treat the UTI in these women to reduce that complication rather than to reduce the maternal vaginal colonisation at the time of birth.
Are there any adverse effects of intrapartum antibiotic prophylaxis?
Yeah, so the risks of intrapartum antibiotic prophylaxis include the risk of increased medicalisation of labour, for example, the need to have a cannula and antibiotics. There's always a risk of anaphylaxis. As we said before, it's quite rare, so a risk of 4 in 10,000 to 4 in 100,000 for women who haven't had penicillin before. And there's a possible impact on the newborn gut microbiota. However, the actual significance of this is pretty unknown, and it's an area of current study. There's also a risk of localized cannula site infections or thrombophlebitis. But in general, the risks of intrapartum antibiotic prophylaxis are thought to be outweighed by the significant reduction in early onset Group B strep and neonatal morbidity and mortality.
And then what if the woman declines intrapartum antibiotic prophylaxis?
So women who decline intrapartum antibiotic prophylaxis should be advised that the risk of their baby developing early onset GBS disease is significantly higher than if they received the prophylaxis. These babies should be very closely monitored for 12 to 48 hours after birth and discouraged from seeking early discharge from hospital. If they've had inadequate prophylaxis, then the paediatric team will recommend a full blood count and clinical surveillance for signs of sepsis in the neonate. Unfortunately, we don't have any alternatives to intrapartum antibiotic prophylaxis at this time. Washing the vagina with chlorhexidine has not shown to be effective in reducing the risk of early onset GBS disease.
And then why can't we just give the baby antibiotics instead of the mum?
So there have been some suggestions about instituting a policy of a single dose of penicillin for all newborn babies. However, this is not recommended practice. The use of antibiotics in newborns in general is associated with alteration to the microbiome, an increased risk in the risk of necrotizing enterocolitis, overall delay in breastfeeding initiation through separating the mum and the infant. And there's an impact on long-term health, including obesity, allergy, asthma, and autoimmune disease, as well as the increased risk of antimicrobial resistance. Now, that's not to say that we shouldn't give babies antibiotics. Remember, the mortality rate of early-onset Group B strep disease used to be 55%, and so antibiotics can be life-saving for these babies. It's more just that the impact of antibiotics on the mother are much less than the impact of giving antibiotics to a newborn baby. So if you can prevent the baby needing antibiotics by treating the mother, that seems to be the best scenario.
Okay, so even though intrapartum antibiotic prophylaxis has caused a huge reduction in the incidence and mortality of early-onset GBS disease, some babies are still slipping through the cracks and becoming severely ill and even dying from early-onset GBS disease. What more can we do to help reduce this?
Yeah, unfortunately, intrapartum antibiotic prophylaxis cannot prevent all maternal or neonatal disease, which supports the case for vaccination in the antenatal period. Vaccination would be expected to induce high levels of GBS-specific antibody in both the mother and the baby, resulting in protection against neonatal GBS disease, both early onset and late onset. Phase 2 trials using trivalent vaccination are ongoing, and the manufacturers are in the process of developing these vaccines. These trials are occurring in pregnant women in South Africa and Malawi and have demonstrated safety as well as efficient transplacental transfer of vaccine-specific antibodies. Vaccine manufacturers are now developing hexavalent formulations covering 6 of the possible 10 GBS serotypes, which would cover about 98% of GBS disease worldwide. The idea is that it would be a single IM vaccination in second and early third trimester.
Oh my God, it's so exciting. Come on, Pfizer. Bring on that vaccination. Another problem we've seen is that neither screening strategy is 100% effective. With the risk-based screening, approximately 40% of babies with GBS are missed, and with universal screening, we may be over-treating some women who don't have GBS at birth and under-treating other women who do. Is there any other way we can test for GBS at the time of birth?
So there has been a lot of talk about a point of care test, so the Group B Strep nucleic acid amplification test, or PCR, which has been developed with a really quick turnaround time of about 120 minutes. So ideally, the idea would be that the woman in labour could have the test performed, and those who are positive are treated with antibiotics, and those who are negative do not get unnecessary antibiotics. While this sounds great in theory, the practical application has had some challenges. Firstly, in order to have a fast turnaround time, the Group B strep are not cultured in enrichment broth, which results in lower sensitivities ranging from 62 to 95%. Now, we could add the enrichment broth step to improve the sensitivity closer to 99%. However, this takes 18 to 24 hours, so it's not really any more efficient than performing a Group B strep culture in the first place. The next issue is the inability to perform antibiotic susceptibility for women with a penicillin allergy. At this stage, this is only possible via culture. However, newer tests may be able to use genetic markers to give antibiotic sensitivity without doing a culture. If we can hone in this test to make it rapid, accurate, cost-effective, and able to perform sensitivities, then we will definitely be onto a winner. Now, the other downside raised about this point of care test is that it shifts the burden of communication about Group B strep to the time of labour. Currently, if a woman tests positive, we can have a discussion antenatally about the implications of Group B strep and our recommendations for antibiotics during labour. This discussion is obviously less ideal when the patient presents in labour and is hearing about Group B strep for the first time.
Good point. Okay, GBS summary. GBS is Lancefield Group B beta haemolytic streptococcus agalactiae. It colonizes 30% of women and is a leading cause of early onset GBS and late onset GBS diseases. Intrapartum antibiotic prophylaxis reduces the incidence of early onset GBS disease to 0.4 per thousand and reduce mortality by 80%. Current strategies, including universal screening and risk factor screening, are still debated, but it's depending on your local guideline. If you're going to test for GBS, do the low vaginal swab correctly and write the correct information on the form, including if a patient is allergic to penicillin. And keep an eye out for point-of-care tests and vaccinations. Keep your fingers and toes crossed. So I think it's time now for some rapid-fire questions.
I'm ready.
Anne, if I have GBS, can I have a stretch and sweep?
Yes. There's evidence that a stretch and sweep does not increase the risk of GBS transmission.
If I have GBS, can I have an induction of labour?
Absolutely. There is no evidence to suggest that cervical ripening, ARM, fetal blood sampling, or fetal scalp electrode increase the risk of early onset Group B strep.
Can I have a water birth?
This is probably the most common question I get asked. No problem at all, as long as you're on intrapartum antibiotic prophylaxis.
Do I need antibiotics if I have GBS and I'm having a Caesar?
If you have an elective Caesar prior to the onset of labour or rupture of membranes, then there's no need for antibiotics. However, if you commence labour or rupture your membranes before the Caesar, then intrapartum antibiotic prophylaxis is recommended. But you shouldn't delay the cesarean section to allow for the 2 to 4 hours of intrapartum antibiotic prophylaxis, though.
What happens if I have GBS and I rupture my membranes at term?
We would recommend immediate syntocinon augmentation and intrapartum antibiotic prophylaxis.
What happens if I have GBS and PPROM? And refer to our previous episode for the definition of PPROM.
Ideally, delay birth until at least 34 weeks, as the risks of prematurity outweigh the risks of Group B strep. After 34 weeks, it's reasonable to offer induction of labour or expectant management until 37 weeks in line with your local policy. For a good summary of the arguments for and against expectant management for PPROM with Group B strep, check out the BJOG articles by Dr. Qasim Mohammed and Dr. Anamine Darui. We'll put the links on our website. And on that note, one of our lovely listeners, Emily, has pointed out that the 10-year follow-up of the PPROMexil trial was published in May this year. Keep an ear out for our upcoming episode, Evidence with Anne, where we unpack the results of this trial.
Amazing. Nice work, everyone. And that's a wrap on Group B strep. We hope you've enjoyed today's episode where we've dived deep into the nitty-gritty on Group B strep and given you fun facts such as Wonder Woman Dr. Rebecca Lancefield's eggnog and the fact that Group B strep causes mastitis in cows.
We look forward to chatting to you next time.